Good evening, and thank you so much for coming to hear this presentation on COVID-19. I'm Robert Clancy, and I'm a clinical immunologist, but I'm also a research worker interested in mucosal immunology and the way in which the surfaces of the body interact with viruses and bacteria. And tonight, I'm going to be talking to you about two aspects. First, I want to talk to you a little bit about the history of epidemics and infections in Australia and how they can give us lessons to better handle the problems of today. And then I'm going to jump forward and talk about some basic science that relates to COVID-19 so that we can basically have some real understanding of what's going on. Tonight, I'm going to talk about three things. Firstly, I'm going to talk about epidemics in Australia in relation to the patterns of health as a background to better understand what's happening today. Secondly, I'm going to focus on the big epidemic diseases that affected Australia. And finally, I want to take those lessons and put them together with some very modern science so we can better understand some of the big questions that we need to ask with respect to COVID-19. First of all, let's look at the way in which disease has affected people in Australia from the very earliest times of Western civilization in 1788 with the First Fleet. Now, what I've done here is trace the way in which disease has affected the population. Now, if you look at the first few years in the left-hand circle, you'll see that the mortality is 5 to 6% per year. It's very high. And people lived an average of only 40 years. And of course, this related to ships arriving from England with many people with typhus and very dysentery and many of those diseases which were lethal. By the time we got to 1830, it had changed. Things had settled down and the mortality had dropped to about 2.5%. And most of the people who were dying from tuberculosis. Chronic infections were the name of the game. As we move forward in the 19th century, in 1830 to 1880, all of a sudden childhood infections appeared. Up to then, there weren't enough children to have a critical mass of people getting childhood infections, and Australia was acting as a barrier, being an island, and with the long ship voyage from England, there was a high level of protection. And you'll notice there's a jump in the mortality as children started dying from whooping cough, from measles and conditions that we now take for granted in children, but they were very lethal in those days. And then we come to a period at the end of the 19th century, which I've called the period of epidemic diseases. And here you'll see overall the mortality has actually dropped now to 2% and people are living an average of 50 years. So there's some improvement in the health issues. From 1900 to 1920, we started bringing into play much better quality public health issues, and we started developing an infrastructure, a bureaucratic infrastructure that was prepared to properly handle infections as they occur. And of course, this period ended with the great flu pandemic, the Spanish flu, where the mortality doubled for a short period of time to about 4%. But the overall lifespan against the background of improving public health had increased to 60. From 1920 to 1950, it's very interesting. What I haven't got on this slide is that the impact of the Spanish flu took 15 years before the mortality rate went back to the pre-1919 level. This is very important when we consider conditions like COVID-19 today. The major pandemic of flu had an impact that lasted for 15 years on the overall mortality. It didn't go away. But this was a period when immunisations became available for children and antibiotics were developed in the 40s and 50s. And so we find overall, particularly towards the end of this period, that the mortality rate had again dropped and now down to 1%, and people were living to 68 as the mean age. And then we jump to the modern era between 1950 and 2020, where we start getting people now dying from chronic inflammatory disease and cancers, and the mortality rate had dropped even further to 0.75%, and all of a sudden we're living an average age of 80. What you also notice is that a new threat starts appearing, and I've called them the zoonoses threat. Zoonoses are infections that come from animals. Now, flu is a classic example, and we're going to talk a bit more about that. The 21st century pandemics were different. The ones we started seeing in the latter half of the 20th century. Influenza never went away. We identified it as a virus in 1933. We know it's a zoonosis transmitted from birds, and it's a mucosal infection. And that's very important because that's a superficial infection where the infection doesn't get past, in most instances, the actual lining tissue of the airways. The second group were the arbovirus group. Most of you will have heard of dengue. Murray Valley encephalitis is an Australian-owned arbovirus, which the virus was characterised by the Walter and Eliza Hall Institute in 1951, and it was mainly in small epidemics in southeast Australia from water birds. Chikungunya is a condition which we don't see at all in Australia, and the transmission of these conditions is by mosquitoes. And because it's mosquitoes, it injects the virus into the bloodstream, and we get not a local mucosal infection, but it's a systemic disease. It involves all the body spread through the bloodstream. The next group are the hemorrhagic fevers. The most classic ones are Marburg fever, which is mainly in Africa, and Ebola, which you have heard of, and these are both transmitted by bat transmission, and again, they're lethal systemic diseases, characterised by bleeding and overwhelming sepsis from the viral infection. Now, the last of these four are the coronaviruses, and that's very relevant today because we know that COVID-19 is a coronavirus. Coronavirus has been around for a long time. They're the cause of many of the summer coughs and colds we get. But in 2003, a particularly nasty mutant variant arrived called SARS. This didn't really affect Australia to any degree, and it was followed by MERS, which was more an infection in the Middle East. Now, these infections were mucosal infections in the first instance, like flu. COVID-19, which appeared in 2019 in China and spread, as we all know, throughout the world very quickly within a month or two, this condition was similar to, but different to SARS and MERS, beginning as a mucosal disease. And that's really an emphasis I want to make throughout this talk. I'm going to go back now in time and talk about the historic epidemics, these great epidemics that have been around for all time. There are three ones that come to mind. The first is leprosy, and the second is smallpox, and the third is the Black Death or bubonic plague. All of these came to Australia in the latter part of the 19th century. Now, they came late and they came in a relatively small way because we're an island continent. And that, again, is very important in the context of COVID-19. We essentially have a ring of confidence. If we can control our borders, we control our access to these very nasty pandemic diseases. And we did that extremely well with leprosy, smallpox, and plague, except for small incursions. The point that I will make about all of these historic epidemics when they did come to Australia is they caused massive public fear, panic, irrational behaviour. The government essentially went missing, did not make the right decisions, and in particular, the press promoted anxiety. The press never really understood the diseases. They were more concerned with providing information that was looked for, but was not necessarily all that accurate. Now, the other interesting thing about these three major pandemics is they had no overall impact on the mortality. They were small expressions in an Australian context. They were treated by quarantine, social distancing and cleansing. Nothing new about that. And treated quite effectively. The great game changer was vaccination in smallpox. And again, there was great political argument about this because the anti-vaccination people were there in force. And although in Victoria, vaccination against smallpox using vaccinia virus, the cowpox, was compulsory. It was not compulsory in New South Wales, although, of course, many people accessed the opportunity of having that vaccination. A small point is that these major historic epidemics have been around for a long time. They actually change by natural selection, Darwinian selection, the nature of the population. And a very small but interesting point is that smallpox had been around involving maybe 20, 25% of the Western world for hundreds and hundreds of years. And it actually selected out of the population a particular cell line or a receptor on cells called the CCR receptor. And this was lost from a small number of people in the population. And later on, this became really important because those people were relatively immune to AIDS or HIV infection. So it's a very small gain for a big downside for a long period of time. It just shows that the impact of these infections can actually mould the nature of the population. The two takeaway points, though, from these historic epidemics are firstly, that we need to know the natural history, and secondly, we need to know the sequence of events that lead to the disease. Now, if you look at these conditions when they occurred, we didn't know a lot about them. We knew a bit about the natural history, but we certainly didn't know a lot about the pathogenic sequence. When it comes to COVID-19, it's a new disease. Every day we're learning more about it, and we've still got an enormous amount to learn. This is making it extremely difficult, but they're the targets. History tells us we need to know more about the natural history, and we need to know the sequence of events because that's the way we can have effective treatment. A little bit about smallpox. Terrible disease, as you can see here. It goes back maybe 10,000 years in the 20th century. That's the 1900s. There, 500 million people died, huge numbers. A third of the people who got smallpox died, and the survivors were left with terrible scars and blindness. You'd walk along a street in the early 1800s in London and you'd see maybe 20% of the population with scarring changes on their face. Variolation, which was giving a low dose of a relatively low infectivity type of smallpox, was introduced maybe hundreds of years ago in India and the East. And that was introduced also into England in the 1700s. But it was replaced by vaccination, one of the great discoveries of the world by Edward Jenner in 1796, where he gave the immunity from cowpox with the lesser amount of downside, because you don't die very often from cowpox. And that's what you are doing by reproducing, if you like, the disease, giving you the immunity, but not the nasty disease. So vaccination was a huge breakthrough in the mid-1790s. Now, through history, smallpox became concentrated in Western Europe, and that became a reservoir for spread to the colonies of the major countries in Europe in the imperial era, and Australia was no exception. I've talked a little bit about natural selection, just to give you some idea of the impact of smallpox in naive populations. That's native populations that had never seen the disease. When the Spanish met with the Aztecs in 1519, there were 3 million deaths amongst the Aztecs from one epidemic of smallpox. Now, in Sydney, the first epidemic of smallpox was straight after the Western people arrived in 1788. There was a terrible epidemic with probably involving many of the Aborigines around Sydney, and we know nothing about this epidemic. There's all sorts of theories that was introduced by the First Fleet, but there's really absolutely no evidence to support that. What we do know is the mortality was terrible. There were dead Aboriginal people throughout the area, and the mortality's been guessed at around 70%. It probably spread because explorers later were seeing people with, and the Aboriginal people with scars many years later as far away as Victoria. We know nothing much about that. In 1881, we had the worst epidemic of smallpox in the Western population in Sydney. There were 163 cases, a quarter of them died, which was about the mortality you'd expect from smallpox at the time. And again, there was the fear, the chaos, the scapegoats, press promoting panic, and the government was quite ill prepared. We talked about the isolation, quarantine, and the optional vaccine, which was non-compulsory but used by the great majority of people in the community, and the epidemic quickly came to an end. Now, the second important epidemic was bubonic plague. Now, there have been 3 great Black Deaths or bubonic plagues. The first was known as the Justinian plague, and the Justinian plague occurred in the Byzantium and was a key factor in the fall of Rome. Came up mainly through Egypt. In 1347, the Black Death arrived in the ports around Italy and Marseille, largely from the wars along the Silk Roads. This was a condition where 1 in 3 people in Europe died within the first 2 to 3 years. It had an enormous impact on the social aspects of Western society, and is given the credit for doing one thing, and that's ending feudalism, because the cost of labour suddenly became a serious issue. Many great buildings, for example, in Siena in Italy, were never completed because there was no labour. This condition died out over a couple of years, or a couple of hundred years really, until a third epidemic appeared in the mid-late 1800s. Interesting, it came from Yunnan, which of course is thought to be the site for COVID-19. And so this bubonic plague, and it was the only one that ever came to the New World of America and Australia, came from China. It infected people throughout Asia. It was a devastating disease, particularly in India. And as I said, it's the first in the New World. Again, there was chaos and fear and a confused government. This is a very interesting disease because it occurred around Darling Harbour, and it occurred between 1900 and 1922 in 10 cycles. In the first episode of 1900, there were over 400 cases, with 1 in 3 dying. The impact was enormous, and one man stands out as having an enormous impact on Australian health and particularly on the plague. And we'll talk about him with the next slide. But it was Ashburton-Thompson that really pinned down the role of the flea in taking the infection from a sick rat to a human, a sequence that had been raised by a research worker in India, but no one took much notice, and he didn't have a lot of data. Now, just to tell you a little bit about plague. Plague is a bacterial disease. The flea bites you, and usually bites you on the leg, and you'll see there's a picture here of a lymph node, which is a collection of lymphoid tissue where the infection spreads, and these huge, painful lymph nodes are the first sign of the bubonic plague. And you can see a picture of the rat catchers, which was quite a big job at that time. They all were very well dressed with their bow ties and their hats and their coats. Now, in that first epidemic, there was huge pressure on Ashburton-Thompson. Thompson said, look, I think this is a disease which we have to treat differently to, say, smallpox, where you use place management. So he was forced, in a sense, to use the same traditional ways of managing the plague that had always been used, by filling the quarantine station with everyone who even looked as though they might get the plague. It was such a fearful thing that people would not let someone who lived next door to the plague even get on the boat to go to the quarantine station. They were put in a rowing boat and towed to the quarantine station so that the people on the boat driving the boat had no contact. It was an extraordinary condition. Victoria stopped New South Wales people coming into Victoria because this was very much a New South Wales epidemic. Nothing much has changed. But Ashburton-Thompson did some amazing things. He actually employed a microbiologist who looked at the 15,000 rats in the first instance, and then set up a surveillance program where, and you can see here the map which has red dots, and in that map you can see that there is a Darling Harbour, and the round dots are where the houses where people got the plague, and the other red areas are where he surveyed 20,000 rats every year and found that where there were areas where none of the rats had the bacteria that could be grown, there were no patients. When the rats appeared where there was a 2%, and this is in 44,000 rats that he looked at, 2% of those were positive, then it started appearing in humans. And this was an extraordinary piece of basic research showing that when the rat got sick and then excreted the virus into the bloodstream, that's when the fleas would leave the rat and jump on humans. And that's when humans would start getting the disease. So when the second epidemic came in 1902, there were far less patients because now Ashburton-Thompson was able to do what he wanted to do, and that is not isolate the human, but isolate the rat and get rid of the rats. It was no sense in filling up the quarantine stations with humans because it wasn't the human that was spreading from human to human, the disease, it was the rat to the human. And this made a huge difference. And in the context of current discussions on economy, it's very important to notice that the cost to the government of the second of these epidemics was reduced by 85% by moving to the system based on understanding the process of the disease brought in by John Ashburton-Thompson. Very important. So the economy which goes with pandemics is very much linked to understanding that disease and intervening in a logical, scientific fashion. Let's jump to influenza. Influenza first probably had been appearing in Australia on and off for quite some time, but the first significant involvement in a pandemic was in the early 1890s. It had come from Bukhara in northern Europe. It took 10 months to get to Australia, and there were 2 cycles of this pandemic over 2 years in Sydney. Now, if you look at Sydney alone, there were 300,000 people infected. It was huge, and 0.24% of the deaths. Just to give you context, we're now looking in Australia with a death rate from COVID-19 of about 4 or 5 times that. But what it did, it established a pattern of high morbidity. In other words, many people would get sick every year or every second year, but low mortality, except in the older people. Those over 70 had a mortality from these annual recurrent episodes of flu of around about 10%. And they die of an exacerbation of bronchitis or pneumonia. So the old people were very susceptible to the standard flu that occurred every year. Now let's look at the way in which Ashburton-Thompson, who by now was head of the Health Department of New South Wales, he actually put out a questionnaire and started asking the right questions, the same questions that we ask today. How was the disease spread? Does the infection give you immunity? We don't know that for COVID-19, do we? And we certainly didn't know it at the time for flu. He recognised the link between the infection and social and economic breakdown. So there's nothing new there. How long was a patient infectious for? How long did the pathogen, the flu virus, survive in the environment? Now, these are very basic, simple, obvious questions, but they were only starting to be asked around about 1890 and by this remarkable person, Ashburton-Thompson. So when we get to the 1919-1920 pandemic, this was a double whammy for Australia because it occurred straight after World War I, soldiers returning to an unprepared society, came back with their influenza. But the government was forewarned and they set up a very efficient, relatively effective quarantine facility, but there were so many soldiers, it was just impossible to keep this disease out. And of course, people being people didn't stick to the quarantine, nothing new there. And over the course of 2 years, hundreds of millions of people, probably a quarter of the whole world population, contracted this particular virus in the Spanish flu epidemic. There was somewhere between 50 and 100 million deaths. Now, in Australia, we had this disease, particularly in 1919, in two waves. We had the first wave, March to May, and a second wave, June to July. There were 2 million people infected, and there were 12,000 deaths at a death rate of around about 0.75%. About 0.75% actually died. Now, the interesting thing here was that about half the deaths occurred in younger people. In Aborigines who got this, half the Aborigines who got flu died. And this is why we recognise that Aboriginal people may be particularly susceptible to COVID-19. So with a track record like that, vulnerable people, Aboriginal people, older people have to be identified. Now, I've just converted this to today's population. If the same 1919 pandemic came to Australia and it had the population of 25 million, we would have seen 60 to 80,000 deaths, massive number of deaths, and much, much greater than the rate we're currently seeing. How did the society respond? They responded by lockdowns, isolation, schools were closed, people didn't work, personal hygiene, and interestingly, a bacterial vaccine, because this was a time when everyone thought that all infections were caused by germs or bacteria, which you could see under a microscope. So when they looked under a microscope, they saw lots of bacteria, which they actually called Haemophilus influenzae, because they thought that must be the cause. So they gave a mixed bacterial vaccine, which makes no sense in a way, and yet there was a 40% reduction in death rate being given this funny mixture of injected vaccine containing lots of different bacteria. If we have time, I'll talk to you a little bit about that because it's a very interesting observation. Now, two very important points I want to make, and that is Australia had a low mortality compared with every other Western country. For example, we had 50% the mortality, correcting for numbers, that they had in New Zealand and England. We had a relatively low mortality. And the second very important point is that the higher mortality in Australia did not return to the pre-1919 mortality rates, that is before the flu came, for 15 years. So this virus was around one way or the other, killing people and causing morbidity to a lesser degree than it did in 1919 for 15 years. It did not go away in a hurry. Now, this is a graph showing the mortality and the two waves. And you'll notice that these two waves are awfully similar. to what we're seeing in Victoria today. Nothing new there. And the second graph shows the incidence of affecting these younger, particularly male individuals, particularly in the first wave and the second wave. So there were some differences that, although, as you can see in the bottom graph, there's this drifting up with older people getting affected. For some reason, younger people were particularly prone, probably because of a very vigorous immune response that the younger people had, which is not what we're seeing in COVID-19. COVID-19 has a lot of similarities to flu in terms of the way it travels through the body, but it also has differences. Now, time doesn't really allow me to go into how flu evolved over the next 100 years, 1920 to 2020, but it's never gone away. It changes from year to year. One point that I will make is that the vaccine that has been developed by flu is not a good vaccine. Some years it's only effective in 10%. It ranges up to 60%. But in the elderly, older people over 65, it's particularly ineffective. Now, we are trying to change that by increasing the dose of the flu antigens involved in the current vaccine. However, even though it has this poor effect in preventing clinical influenza, a very interesting study done in the early 2000s by a woman called Dr. Nicole in the States showed that there was an overall reduction of death in older people by 17%, totally unrelated to apparently getting flu. And this was mainly people with heart and lung disease seemed to live a little longer if there was a flu vaccine. And this is really the most important reason why people get the flu vaccine, and we really emphasize its value in older people. Not so much that it reduces getting a cough and a fever, but it seems to have an impact on the overall death rate in older people. And again, this is something we could talk about if we had time, and possibly relates to the changing bacterial content in the airways of older people. I will make the point that when people get severe influenza, it spreads from being confined to the airways, because usually it doesn't get past the lining cells of the airways, which is exactly what happens with COVID-19. But when it does spread, it has a catastrophic effect, and it can be quite lethal in older people with abnormal bacteria in their airways. It can activate those bacteria and they can get pneumonia. And if it gets systemic, that is, it spreads widely in those people, it will create what we call a cytokine storm. And that causes multi-organ failure. And if you go to the intensive care units when the flu season's on, you'll see people there very, very sick and sometimes dying from what we call a cytokine storm, or the extraordinary overreaction by the body's immune system to this virus, which is now spreading through the body. Again, a similarity with COVID-19. So what are the big lessons that we need to learn from these epidemics? Firstly, we need to know the natural history. We're still learning that with COVID-19. This allows us to anticipate the clinical course, whether there's going to be second waves, how long you might expect this to be around in the community, risk factors. It allows us to manage the clinical situation and allows us to focus on combining the clinical management with socio-economic issues. And I refer back to the great impact that Ashburton Thompson was able to make around the world by showing that you manage the rat, not the human. And by understanding that process, it had a huge impact on the outcome of both clinical and economic factors. The second is to know the pathogenesis. What is the sequence? And I'll just run through some interesting points from these great epidemics of the past. Leprosy has very interesting interactions with flu and may well have the same impact of COVID-19. In Nauru, for example, there was one person with leprosy in the whole of Nauru when Australia was mining phosphate rock there. When the New Zealand ship arrived, it brought flu in 1919, and 22% of people died on Nauru because they were a naive population. But all of a sudden, within 2 years, 23% of people in Nauru had clinical leprosy because the flu virus reduced the immunity and allowed latent leprosy, which hadn't been diagnosed in these people, to become clinically evident. I talked about plague and the importance of surveillance prevention, smallpox, and I've talked about genetic selection and herd immunity, the vaccine impact, and influenza. We've talked about those aspects. Now let's talk a bit about science, because so far we've talked about lessons from history. Well, I don't want to bamboozle you, but this is as simple as I can make immunology and infection. If you get an infection, it can happen in one of two ways. It can be a systemic infection coming through the skin or in whatever, it invades the blood. Or it can be confined to the mucosal lining of the lung or the gut. Now, the importance of understanding this is that if you get a systemic infection, you develop what we call systemic immunity. You get antibody that circulates in blood. We get T cells, these two arms of the immune response, the antibody and the T cell. And this gives rise to specific immunity. Now, if you can think about it, there's about 10,000 different patterns on viruses and bacteria that the body needs to make a response to. And so you don't have a great number of T cells and antibodies for any particular virus that may come along. And so the specific immune response, which is only a few cells, needs to recruit an army. It's as though the specific immunity is a general in the army, and the foot soldiers are the innate system. They have guns and they just fire off when they're told to, whereas the plan comes from the general. And so this innate system is non-specific. And the relationship between the bug, the bacteria or the virus, and the way the body responds is known as the host-parasite relationship. And depending on the connection and how effective and efficient this innate immune system and the specific immunity come together, you either get complete resolution of the infection without symptoms, or you get an inappropriate and excessive amount of body response, and that causes the damage. Not the virus or the bacteria, but this massive response from the body. And I think if you think back to influenza, you can see that's exactly what's going on in the people who get very sick. Now let's go to something like influenza or COVID-19. That comes through the airways and is primarily a mucosal infection. And that activates a very different set of immune responses. The antibody is an IgA antibody, not the IgG antibody you see in blood. The cells are not the T cytotoxic cells we see in the blood. There is mainly what we call Th17 cells, and they come from a very interesting group of cells that are called aggregate cell or Peyer's patches in the gut. And again, time doesn't give us the luxury to go into this in great detail, but what happens is, as you'll see in a minute, the lung aspirates all the contents of the lung into the gut. So we're swallowing about a cupful of mucus without knowing it every day as a normal event. And anything in that goes into the gut and activates the cells to stimulate this mucosal immune response occurring in the lungs and the gut through a system known as the common mucosal system, which is like having on the cells that come from the Peyer's patch a stamp that says, take me to the lung, take me to the gut. But don't let me contaminate the systemic immune system to any extent. So when we look at vaccines and development in COVID-19 or flu, we find that vaccines work well when you get good immunity that follows an infection. So with measles and mumps, we get great immunity. With flu, we don't get good immunity because you do not get good durable immunity in the systems that involve mucosal immunity. The mucosal-limited infections are generally followed then by poor immunity. And we know this with the infections that occur in children. They keep getting the same infection year after year. And so you can't expect a vaccine to do what the disease itself might do. If the disease itself is followed by long-term immunity like smallpox involving the systemic immune system, that's terrific. You can expect a great vaccine, but you won't get it for things like flu or RSV and coronaviruses. We know that coronaviruses cause recurrent infections. They cause recurrent coughs and colds. We never got a good vaccine for SARS or MERS, the two ones we talked about. Now, vaccine efficiency is therefore best if we present the vaccine in the compartment of the infection. So if you inject a vaccine, you're going to get good immunity in the systemic immune system, but you won't get good immunity in the compartment of the airways or the gut because you don't get a lot of exchange between the two systems. And mucosal vaccines, which might sound very logical, are not particularly effective because you have a high level of suppression of immunity occurring. And that's essentially to prevent the mucosal surfaces from blowing up in the presence of a sea of infective organisms. Now, this is not done by a particularly well-known artist, but it's to show you what I've been trying to talk about with mucosal immunity. On the left, you can see a schematic lung. This is the airways of the lung, and you can see in the green that people are swallowing the contents of the airways coming into the gut through the stomach, and these little Peyer's patches here are generating the T cells, known as Th17 cells, which specifically migrate back to the lung. So we have this loop. This is the way the airways are protected, and this is what COVID-19 requires if it's going to limit that virus to the mucosal compartment. So this is a very important thing to understand, and it's not understood by most of the people who these days seem to be talking about vaccines and what's going on in COVID-19. Now, in this not such good diagram, for which I apologise, you can see on the left a little black dot, which is a virus, and here it is going into a receptor in the T cell. Now, we talked about the T cell as being the specific immune response that recruits all the soldiers. Here's the general, and here are the foot soldiers. These are the molecules that the cell secretes so that it can recruit protection against this virus. And you can see there's a linkage between the specific immunity and the innate or the non-specific immunity here. And depending on the connection between the two, if it's a very good connection, you have a happy outcome and the virus doesn't cause too much damage. If this connection is poor, then you don't translate very effective immunity. The immunity, because it's less effective, allows many viruses to divide and to become a large load of cells. It's all about the load of virus. If the load of virus expands and gets bigger and bigger, you get a catch-up system where you get more and more of these Th17 cells trying to cope, but they don't because they're producing large amounts of foot soldiers, which you remember are non-specific. So while they were damaged, like having a hand grenade, they'll kill the virus. That hand grenade, if there's lots of them, will also kill the host tissues, and you go to a very unhappy person. So let's look at this on a graph beneath here, and you'll see that in a healthy person who connects the two components of the immune response, you get a little blip of inflammatory mediators below the threshold, which would lead to disease. Where we get poor connection, we get huge amounts of inflammatory response. We call that a cytokine storm, or we get lots of activated neutrophils and various effector foot soldiers, which are non-specific, causing tissue damage. And that's all about, if you understand that, you understand COVID-19. So if we go to the next slide, we see that in normal people, young people, who have an active, good connection between these two components of the mucosal immune response, the virus comes in, infects, and is quickly eradicated, and you get a small blip of inflammation. What happens in older people is you get a disconnect between the two components of the immune response. The specific and the non-specific components are not linked as tightly as they are in young people. And we call that immune senescence. and you suddenly see this massive amount of virus. And when you get the massive amount of virus, it produces this massive immune response, which is like hand grenades going off in the lung, and it spreads into the blood, into the liver, the kidneys, and you get systemic disease. These are the people who are in intensive care in our hospitals today. They're not the people who are getting mild infection and not going to hospital. So you can see here is the person, the young, healthy person who gets a mild infection, doesn't go to hospital. Here is the person who goes to hospital and ends up in intensive care because they do not link these two components of the mucosal immune response. Now, let me just give you some data, because this is Science Week, remember. And this is from studies that my group in Newcastle were involved in a couple of years back. And there are 3 studies here, Newcastle, one done in Perth and one done in New Guinea by Mike Alpers, who some of you will know. Now, here I've shown these are all people with chronic cough and sputum. They're people with chronic bronchitis, they've got damaged airways, and they're liable to getting severe infections when they get the flu or COVID-19. It flares up into what they call exacerbations or severe infections. We know that one of the organisms in this instance is one called non-typable Haemophilus influenzae, same one that I mentioned earlier in relation to flu epidemics. Now, if you get these infections in these older people, they do not connect their two components of their mucosal immune system very well. And so if we improve that connection by feeding large amounts of these killed bacteria, they activate that Peyer's patch and bring those Th17 cells quickly and efficiently to the mucosal compartment. And what you see is a protection against the flare-ups that would otherwise occur when they got an inadvertent virus infection through the winter period. And you can see here that there's a protection of around about 30 to 90% against these acute flare-ups when you feed these large amounts of non-typable Haemophilus influenzae. Now, I'm giving that as an example. I don't think that would work too well with COVID because this NTHI is not a very powerful stimulant. However, we do know that some of the other bacteria that we've been studying are much more powerful, are much more likely to be able to generate the type of protective response you would like to see in an older person to give an older person a younger people's lungs. So to me, as a mucosal immunologist, this is the focal point that we really should be looking at, trying to improve the way in which everybody responds to the initial meeting of a virus. So the virus is not a good virus, but it's not the virus that's killing you, it's the body's response because it's delayed and exaggerated and non-specific. This, I won't, because of time, I won't go. This just simply shows you that if you look at the age effect, you find much less protection in older people. Again, fitting this idea that older people don't connect their specific and non-specific components. Here's a 30% protection in younger men. There's a 30% difference in protection between young and older men. Women, much less so. And this is what we call immune senescence, aging of the immune system. So what do we learn about COVID-19? And I just want to finish with these comments. COVID-19 is a two-phase disease. It's a mucosal disease like flu. It only becomes systemic when you don't connect the immune response very well. The important point is you must treat COVID-19 very early, at worst in the first 2 days. You don't wait and sit around till going to hospital. And there's been so much nonsense talked about hydroxychloroquine and now ivermectin, very interesting products that are particularly effective if you use them early. So these new drugs, or they're old drugs, that are coming back and not favoured by the drug companies who like to have patents and like to be able to charge a lot of money. These are cheap products available now, and they're not dangerous drugs. They're drugs that have been used for 40, 50 years. Of course, you get side effects with everything, but it is not the dangerous drugs that some people have been talking about. So the message I want to give you is that COVID-19 is a early mucosal disease, a late systemic disease that kills you and causes you to become very sick. The treatments that need to be used and which are effective in many studies now need to be used early. Everyone, in my view, should have some hydroxychloroquine at home or Influenza so that if they get a sore throat or fever, they do two things. They go and get a swab and they start treatment within 24 to 48 hours. That, I think, is the best way to read the data that exists. So it's early mucosal disease, response is critical, and immunosenescence, which delays mucosal disease, makes certain people very at risk. And injected vaccines, the ones we hear about all day, in my view, are not likely to be particularly effective because they, of the precedent of influenza, of other coronavirus vaccines, have not worked particularly well because they do not give you the protection in the early phase that you need. I think that they will be effective in reducing the spread between younger people. I think from that point of view, it could be very valuable. So I'm not knocking the injected vaccines. I'm simply saying that, in my view, it's very unlikely they're going to have a big impact on the target people who are older and have collateral diseases. So I hope this has given you some insight into what's going on, some understanding of interpreting all the news that we get, some of which is not terribly accurate, understanding what we may or may not expect from vaccines and where we might expect COVID-19 to go. And I think we can learn so much by looking at the history and at modern science. And thank you so much for sharing some time with me.